Hello, everybody. I'm Ryan Chua. I'm a pulmonary critical care in central Massachusetts. I'm based out of UMass Health Alliance Hospital. I hope I find everybody safe and healthy. I would like to thank PMA New England for giving me this opportunity to contribute to the discussion, the discussion regarding this global phenomenon, COVID-19. Next slide, please. So I just wanted to show this symbolic picture, and it'll have more meaning as we flow through the discussion, but this is a very old picture, John Wayne, and he's in the Wild West. So within me, there's this discussion that we're kind of in that mix of diagnostics and treatments, and we're trying to find the quickest one. So like this Cowboys, they try to do a quick draw, but we're also trying to hit the target. So we have to balance how quick we are to approve this medications that we have available, how quick we are to approve this tests that we have available versus the accuracy of what we're doing or how effective on what we're doing. Next slide, please. So just a slide from the CDC showing we're essentially at higher risk for severe illness. Just in the quick summary, it's essentially people who are over 65, patients who have underlying chronic medical conditions, and especially people with chronic respiratory, chronic kidney, and diabetes and obese patients. Next slide, please. So one thing that was one piece of data that was not included in that discussion by the CDC, we could probably talk about, which has gained some media attention, is racial disparities also with regards to infection rate. So I'm just going to focus from the Boston area. So if we go through the U.S. Census from the 2019 information, Boston is mainly white population of 53%, African American 25%, Hispanic 20%, and Asian about 10%. But if we go to the racial data with regards to COVID cases, we can see that there's a disproportionate increase or higher number with regards to the Black population. So it's there's 38% of who's picked up to have a COVID infection as compared to their 25% actual population in the Boston area. So, and this has been kind of echoed or seen also in the different, in other cities where there's a higher rate of African American and Latino or Hispanic COVID cases. Next slide, please. So I'm just going to break down my discussion into who could probably stay at home if they have COVID-19, who probably should be directed inpatient, and who eventually gets escalated to the intensive care unit. Next slide, please. So when we look at our patients for the clinicians in this discussion, we look towards their risk factors. Are they over 65? Do they have asthma? Do they have COPD? Are they residing in a nursing facility? Do they have a higher BMI of over 40? And are they active smokers? So these patients have a higher risk of developing a more severe reaction or a more severe COVID-19 infection. We also talk about how short of breath they are. So these are questions that we can pose to our patients, and we can even do this potentially remotely, like with televisits, over the phone. So when we talk about shortness of breath, we divvy it into, are they having some mild shortness of breath? Is it moderate? Is it severe? So mild shortness of breath essentially means if somebody were resting, they would essentially be asymptomatic. But if they did more effort, then they would get short of breath. The moderate shortness of breath level means at rest, they're asymptomatic, or they're not necessarily short of breath, but even a minor amount of effort would get them short of breath. And people who are severely short of breath, you know what, you could be sitting down, you could be resting, and they're still short of breath. So that patient you're kind of thinking, okay, does this patient have to be in a medical facility, or do I have to direct this person to the emergency department? And so so also more recently with the availability of pulse oximeters in the pharmacies, I've actually discussed with my patients that potentially would be a good investment of about $30 to $50 to purchase a pulse oximeter if you can find it. And the importance of this is also triaging the patient. Can they stay at home? Should you have the radar up to try to send them to the hospital, or is there like really that number? Do they have to be in a medical facility? So most patients who are above 95, even if they get diagnosed with COVID, O2 sats 95, they're not short of breath or minimally short of breath, then you're kind of thinking, okay, O2 sats still pretty good. They can stay at home, but as they go down below 95, 94, 93, then you should have your radar up. I'm probably thinking, okay, I'm probably going to have to follow this patient up a little bit closer. And once the number goes down to below 90, then that's a trigger. Okay, this patient has to go to the emergency room. And then I'm calling my colleague in the emergency room, giving a heads up. Okay, I got this patient who's coming to see you guys soon. Next slide, please. So when we deal with patients in the hospital, a lot of them have different complications or a lot of issues with COVID. And it's so interesting the variety of stuff that COVID can present with. But a lot of them will present with respiratory issues. And there goes, as we talked about, the need for oxygen. So oxygen supplementation, we're trying to get above 90. We're trying to maintain an O2 sat of around 95. And as they come into the emergency room, they will get their metabolic panel checked out. I just push for like a complete metabolic panel, look at their liver function, look at their kidney function, and that will play a role down the line when we're looking to actual therapy or potential therapy that we can provide these patients. We're looking if they have acute kidney injury, if they're dehydrated because they have not been eating or drinking well. And I recommend that typically, this patient should be on telemetry if it's available, given that they can have cardiac complications, include arrhythmias and cardiomyopathies. And when they're inpatient, there's always that mental struggle given we're always thinking about antibiotic stewardship, but when we see those patients, a lot of them will have X-ray findings of pneumonia. So there's always that question to give or not to give antibiotics. But typically in our center, if we do see pulmonary infiltrates on the X-ray, then there's more of a trend towards providing antibiotics to cover for possible secondary bacterial infections. You can finesse it a little bit also by checking some other lab markers to see if you would lean towards giving antibiotics versus not giving antibiotics. And also consultation with a specialist with infectious disease, with pulmonary, may be of benefit to some of these patients, but not everybody needs a consult anyway. So next slide, please. So so going through the spectrum of the patients, typically the killers, essentially the majority of people die from ARDS or severe hypoxia, which is low oxygen. And typically ERDS means that the X-ray has infiltrates both sides, and at the same time, they do need a lot of oxygen to maintain a certain pulse oximeter level. Patients can have sepsis, unstable vital signs, have a drop in their blood pressure, have a pretty high heart rate, and a lot of they can also develop organ dysfunction, kidneys, cardiac, neurologic dysfunction also. Next slide, please. So these are slides of, these are two X-rays. One on the left is that of a healthy person, so more of a crash course. A healthy X-ray would show the heart in the center of the picture, and we can see pretty symmetrical rib markings, and essentially the lung, which is dark gray to black, is fairly clear. We see good margins around the heart and a good margin with a diaphragm, and it's almost like a wing shape.